Hello, this is Jon Mizgala, and we are going to go through the musculoskeletal system as a review. So the first thing that you should think about in regards to musculoskeletal orthopedics is when considering terminology in orthopedics, this can help you describe what you are finding to other people within the profession or even during your documentation. So some things you can think about when looking at this terminology, we're not going to go through all of it, is things like adduction and abduction. So adduction is movement. That should say toward the body, and abduction should say away from the body. So when you're adding something, you're moving it towards the body. So adduction is towards, and abduction is away from the body. You get your different bones of your hands and your feet. Then you think of location-based things such as proximal and distal. So a good way to think of it is distal is a part away from the center of the body. So it's distant from you. Flex versus extend. So if you're flexing your arm versus extending your arm, you're bending versus straightening. So if you do this with your arm right now at the elbow and you bend, like you're flexing your arm, you're bending that joint and flexing your bicep muscle. If you're extending your arm, you're making that arm straight. Circumduction, good way to think about that is just circular movement, right? Circle, circumduction is right there in the name. Structures can be helpful. So the musculoskeletal system, right, is comprised of bone, tissue, muscle, tendons, things of that nature, right? So it's the same makeup throughout your body. So these are just some examples of skeletal structures. So you've got your connective tissue, so that can be found. Essentially, think of where your skull fuses together. You've got your spinal components. So cartilage is the tissue or the substance that's in between the different vertebrae or your bone, which actually acts as the padding and support. You've got that cartilage throughout your body, so it's also in your pelvis, it's in your hip joints, it's in your knee joints, right? It's bone, cartilage, muscles, and then things that hold everything together. It's kind of what makes up the majority of your your musculoskeletal system. So when thinking about orthopedics, you have to be mindful of how things move. So same principle, right? So you have your hinge joint. We talked a little bit about this already. This is your elbow, your knee, anything that functions in a hinge capacity. Good way to think about this is a door hinge, right? So if a door has a hinge on it, they open and close in one direction. Not to be confused with a sliding door. That's not a hinge joint. A hinge joint is anything that just rotates or moves back and forth in the same motion based off of that available hinge motion. Then you have something like a ball and socket joint. So think of your shoulder here or your hip. So this is where the bone ends in a ball type of component and fits in a socket. So the hip is the picture that's shown, and that allows for more of that extensive movement, right? So you can do flexion, extension, abduction, adduction, circumduction. Think about the way your arm moves at the shoulder. Think about the way your arm moves at the hip, right? That movement allows you just more complete aspects within the plane of motion. And then you have some other components. So pivot, condyloid, saddle. A lot of these are in your hands and feet, gliding. So this is things that are moving back and forth on each other, right? So for the pivot, think about as you twist your arm back and forth, like you're opening a door handle or you're taking a lid off of a jar. So as the bone overlaps on itself, that creates that rotational component. Condyloid, so that's more at the wrist, so you have a little bit more extensive motion there, right? So you can flex, abduct, abduct and adduct, circumduct, so there's a lot more mobility. It's not a ball and socket joint compared to the hip and the shoulder, but allows for very similar movement. And then you're left with things like your thumb, your hands, and the bones within your hand do technically move when you're doing things, right? They're not a rigid structure. They don't move a lot, but they do move over and around each other. Same thing in your feet. This is just a zoomed in picture of the knee. So we already talked a little bit about this. It's the cartilage right here. And then you've got your bursa, which is that fluid-filled pad of support and protection. got your bony structure, your tendons, like we talked about, that come around it, and then just the different levels of, blood innervation, membranes, and so on and so forth. The good news is this particular type of layout is very consistent for much of the musculoskeletal system, right? You've got your bone, you've got your cartilage and or bursa to act as padding and support. It also helps with movement. You've got your tendons and your ligaments that holds everything together. The tendons are attached to the muscle, so this helps you with actual strength of movement. You've got your nerves and your blood supply. So again, very similar structure throughout the body in terms of the musculoskeletal system. So there are different ways you can evaluate orthopedic injuries or orthopedic pain, one of which is the McMurray test. So this is a test we use to look for injury to the medial meniscus. We're not going to go into detail in terms of how to perform these tests, and there's some videos throughout this presentation that will allow you more opportunity to see the mechanisms in action. But what happens here is you're essentially applying stress while twisting and turning the knee, right? So the meniscus is in here towards the knee, and it's one of those parts that acts as support and padding. So when that tears, you're going to have pain, you're going to have some difficulties with these maneuvers. So realistically, any maneuver in orthopedics, what you're trying to do is elicit either some sort of pain or some sort of derangement, whether that's clicking, popping, snapping, something outside the normal expected movement motion. This becomes important because you also have to know what normal is. So if you don't know what normal is in terms of rotation or fields of motion, then it's going to be very hard for you to identify abnormal. Drawer sign, so this is to look for ACL or PCL, which are your ligaments, right? Anterior cruciate ligament, posterior cruciate ligament. So again, think of the ligaments as structures that help support and stabilize the various joints. So these are tests you can do to see if there's any instability of these ligaments. So again, it can be helpful to think about your anatomy here, right? So your ACL is the anterior. So if we remember our medical terminology, the anterior is the front part of your body, posterior is the back part of your body. And you can see what we're doing here, right? So essentially you are pulling the leg in a direction where at some point those ligaments, if they're functioning as expected, will stop the leg or the knee from moving any further. Same thing if you're pushing down on it. So if you're going too far in a direction where you would expect it to stop, that should cue you in that something is unexpected. And the reason, so like you're pulling here and pushing here. So if you think again, the posterior ligament, if it's intact, will allow a little bit more stretch and flexibility in this direction. Whereas the anterior ligament should stop you at a reasonable place, right? So you should get to a point where it's just going to not let you pull anymore or not let you push anymore. So if that wall, so to speak, is no longer doing what it's supposed to, there's nothing stopping you until you fully tense the alternative ligament. So again, having an idea of your anatomy becomes important here. Lachman's test, this is just another test you can do to elicit ACL damage. So as we go through, right? So the common theme is pain. So a lot of orthopedic problems can cause pain, and they're all very similar in terms of etiology. So location can be different, but as we talked about, the structure that makes up those locations is not significantly different. It's bone, some sort of connective or padding tissue, it's blood innervation, nerve innervation, and the ability for movement. So if you have things like back pain, so acute versus chronic, you have to take into consideration your mechanism, right? So was there an injury? Is this something you were lifting a box and then you had pain, or is this something that you lifted a box 2 years ago and you've had consistent pain since then? That helps you go down the different pathways of what to do. So from an acute perspective, some sort of muscle strain is the most likely etiology. You've essentially irritated the supportive muscles of the back around the spinal column. When you get into more chronic issues, there can certainly be a muscular component to it, but this is where you're looking more at things like stenosis or disc disease, right? So if your normal spine is well maintained, well aligned, and you see your cartilage in between, which acts as support and padding. It also allows for open space, so you have your spinal nerves that go down through your spinal cord. This is meant to be in a relatively big enough hole where nothing's irritating it, right? The nerves don't like to be irritated. So if you have stenosis or degeneration or disc disease, you essentially have a collapse of some of these structures, right? This cartilage can thin, this canal can become narrow, the nerve can get compressed, and then is what leads to people, saying they have something like sciatic or that numbness and tingling, that nerve pain, that degeneration, that movement of the bone within there, the herniation of some of those disc components can create irritation on that nerve, which leads to some of those neuropathic symptoms down the line. And then remember, again, your level of irritation on the spine is going to dictate what symptoms you have. So irritation in the neck is going to affect a larger section of the body as opposed to something in the lower half of your spine, right? Remember, knowing your dermatomes and where your nerves enter and exit the spine and what they innervate becomes very important. So again, anatomy is probably one of the bigger take homes in terms of orthopedic related issues and diagnosis, because without really knowing your anatomy, it's going to be hard to really understand um, the potential cause for problems. So when we're talking about acute musculoskeletal stuff, the other nice thing is for the majority of your injuries, your treatment is going to be very similar, at least to start with. Now, obviously, if you have fractures or significantly traumatic injuries, this will change. But for the majority of your sprains, your strains, your pulls, what have you, you're going to start very similar. Rest, ice, compression, elevation. Protection is the newest one that's been added. So price or P-RICE, right? So you want to protect the joint or the location from additional injury. Rest is a big thing. So the musculoskeletal system works very hard at moving you, keeping you upright, keeping all of your structures supported. So if something in there is damaged because of an overzealous motion or a strain or whatever, it needs time and rest to heal itself. The body's very good at getting itself back together. It just needs an appropriate amount of time to do so. Ice can help with swelling. Heat can help more with pain to an extent and relaxation. So remember, as you cool things, everything kind of stops. So that's where the swelling comes in. You're stopping those extra components coming in and swelling the area. Heat, you're more dilating and relaxing. So it can be helpful with muscular type pain after the initial 48, 72-hour period. Compression, falls in line with support or protection. So this can be helpful for swelling, just to provide some stability. So think of like an ACE wrap on your ankle. Elevation, this goes in line with rest as well as swelling. So you're elevating something ideally above heart level, and that's just helping the body bring back some of those components to different places. Something like anti-inflammatories, Motrin, naproxen can be very helpful to help with swelling and pain. Obviously, be mindful of the contraindications to something such as Motrin or similar. In those cases, you would use Tylenol, if able, or either other local measures. So again, ice, compression, use topical pain relievers such as Icy Hot, Bengay, or anything in that family. So, pharmacology is a part of your treatment spectrum as well. Degenerative disc disease, we already talked a little bit about. So again, this is your normal disc, right? So you've got a well-maintained space. This allows for that movement of your spine, flexion, extension, slight rotation. As it degenerates or breaks down, you see how it gets closer. So it's more restrictive in here. It's thin, it's herniated, meaning it's pushing out towards a direction. It's bulging, it's starting to herniate, but it's not quite fully, those contents are quite fully out yet. Osteophyte formation is just this bone has now started to change as a result of that degeneration and irritation. So, comparatively normal to abnormal, you can see how this might cause more pain, cause more restriction of mobility, and just general discomfort. And remember, right? So the spine is a big thing because you literally need it to do just about everything in your life: to walk, to stand upright, to move. It houses nerves. It does a lot of things for your body. It acts as one of the foundational structures of your skeletal system. So if you don't have a spine, or you have an ill-functioning spine, you're likely going to have some more difficulties throughout the day. Osteomyelitis, switching gears a little bit, right? So we've kind of focused mostly on pain, strain, and some natural changes, if you will, or accelerated changes. But remember, bone can also get infected. So this is an issue because if we can see where that infection is, right? So then it just starts to spread and affect the bone, both old and new. Obviously, as the bone becomes infected, that has the potential to spread to other places, but also just wreak havoc within the bone, right? We just talked about how the bone is the supportive structure by which you move and live. So if that becomes irritated or less stable or supportive, obviously you can have some negative downstream effects as well. Acute versus chronic, this is just in terms of osteomyelitis, but general idea, the shorter the time frame, the more acute it is, the longer the time frame, the more chronic it is. Uh, Osteomyelitis, I like to bring it up because I don't know that you'll see it a significant amount in practice, but it's something you should always consider, especially in instances, say someone's diabetic and they develop a foot wound, right? There's not a lot of tissue and muscle and supportive structures between the outside world and the bones in your feet. So this is a big reason we have diabetic patients check their feet routinely. We do diabetic foot exams looking for wounds because as a wound gets in there, the opportunity to spread to bone becomes a little bit higher. Some diagnostic things you would do, very similar to anything else you would look for in terms of an infection, with a little bit more emphasis on imaging to get a better idea of the level and degree of irritation to that bone. And then treatment is just a very prolonged course of antibiotics. Sometimes it's amputation, right? If the infection is too severe and the tissue, the bone can't be salvaged, then the idea is, do we just sacrifice that section of bone so that it does not cause any other irritation elsewhere, taking into consideration quality of life and things of that nature. This is just a comparison between normal and osteoporotic bone. So remember, osteoporosis is essentially the loss of bone density. As you get into primary care, you'll be thinking about things like your DEXA scans. So this is a way you can measure bone density, especially as individuals get older. As that density decreases, you have the opportunity for more fractures or deformities of the spine or any of the other bones. So our goal here is to do a form of screening to certain sections of the population and those that are at high risks so that you can minimize the opportunity for things like fractures or falls or what have you. So osteoporosis is what's being represented in this picture. So another degree of joint irritation and inflammation would be your rheumatoid arthritis. So remember, we talked a little bit already about osteoarthritis, which is that degeneration of the bone, and that's usually due to a big breakdown of this um, lining, that protective cartilage and support, as it breaks down, usually due to use, activity, wear and tear of life, right? That bone starts to rub on each other and you get some of that degeneration. Rheumatoid arthritis is a very similar idea, but remember that this is an autoimmune process. So your body is actually attacking itself and creating this inflammation, this irritation. So as it goes through, it just breaks down a lot of the supportive structures, and then you get erosion and you get inflammation, and you just have a lot of issues. And then this can be a common sight you see in somebody with more advanced rheumatoid arthritis, right? And then you have to think about the treatment component, which would be, going down that rheumatologic pathway and treating it as you do a lot of autoimmune diseases, but also taking into consideration things like pain, support with ADLs, because as you might imagine, it can be difficult to do a lot of your day-to-day stuff with this restriction and limitation of your joints, specifically your hands. Here again is that difference with osteoarthritis. So if we see now, you see how this is essentially just a breaking down due to loss, and then you get the development of bone cysts and spurs and things of that nature due to that bone-on-bone sensation. So rheumatoid arthritis, the body is essentially attacking this space, whereas osteoarthritis is just damage over usually years of time, repetitive damage to the area. Similar issues you can get. So you have your nodes here, right? So you get that overgrowth, if you will, and that's this down here is what you're looking at. Those are your Herboden and Bouchard nodes. So it's essentially just swelling and inflammation of the joint space because it's that disorder of the synovial joints. So you get stiffness when waking, you get that overgrowth of bone tissue, and you get some restriction and pain. Again, this is just in comparison to rheumatoid arthritis. You get the morning stiffness, which can last a little bit more consistently compared to the osteoarthritis. When you get up and moving, it becomes a little bit easier to go on, whereas your rheumatoid arthritis, that stiffness can linger and you can go in and out of periods of pain due to that inflammation of the connective tissue, right? Similar type of etiology in terms of, or similar type of presentation in terms of your bumps and nodules, because as you affect the joint, you can have other uh, clinical changes. Talk a little bit about fractures. So fractures are primarily diagnosed through X-ray. So a reminder that you know, so a fracture is a disruption of the bone, right? So if you have normal bone, and this is why again knowing your normal and your anatomy becomes important, because if you don't recognize that this is abnormal, or that a normal bone does not have that gap in there, it's going to be very hard for you to detect abnormal. So part of your evaluation for this is performing what's called snuff box tenderness, where you press essentially at the space at the base of your, well, where your thumb and wrist meet. That space there is affectionately known as the snuff box, and that's the most direct path that you have in terms of trying to press right on this bone. So if that elicits pain, your suspicion of a scaphoid or a navicular fracture should go a bit higher. Obviously, your X-ray is going to be helpful, but you can have a percentage of X-rays that do not demonstrate this initially. So this is where you need to combine your clinical suspicion with the diagnostic testing that you have. And we'll talk a little bit about, or talking a little bit about the treatment for some of these injuries. But, you know, generally speaking, when you go down that treatment pathway, splints and slings and things of that nature, realistically, they're restrictive in the sense that it can be bothersome, but you can, utilize them at a relatively low risk to the patient. I don't know why there should have been a picture of a navicular bone. So navicular bone is in your foot as well, but that's all right. I think we circle back around in a minute here. So ulnar deviation. So the Finkelstein test, this talks more about um, almost like a tendinosynovitis of some of these structures, right? So we already talked about that. You have your tendons, your ligaments, your supportive and uh, comfort-based structures. So what we're doing here is you're essentially overstretching some of these tendons that are in here, and you're trying to elicit pain with this maneuver, right? Again, this is where having an idea of your anatomy, and you know, as you go along, it can certainly be beneficial to learn names of the tendons and the bones and all the structures, but realistically having an idea at least of, you know, what does this anatomy look like? What is in this area that I am eliciting or stretching? What am I trying to elicit with pain in this area, right? So if I know that I'm stretching certain tendons in this area, then that gives me a better idea of um, what to do with it, right? Because I know that this maneuver causes pain because of this local issue. So now we talk a little bit about some of your treatment options. So splints can be more common, and you'll go through this a little bit more at your immersion experience. Your splint application and monitoring and things of that nature is a little different based on the location, but the idea is the same. You're essentially provided a semi-rigid support that does not allow for a lot of movement of either that bone or some of the other structures in the area, right? Again, if we think about rest is the big thing, your body will do its best to heal itself eventually. It just needs time to get there. Elbow pain. So these are some of your common presentations. So again, remember, so when we talk about affectionately things like your golfers and tennis elbow, what it is essentially epicondylitis of that structure. So you have your inner and outer, medial and lateral components, and this gets inflamed here. So as this gets inflamed, you have that pain with movement as this stretches and contracts, right? So as you move this, that's what it's going to elicit that pain. So obviously the big thing in this area is your history and physical. So talking about, aggravating, relieving factors, repetitive motions, but also on your physical exam, trying to differentiate, is it more inflammation of some of those muscular tendon-based structures, or is it bone irritation in itself? Bursitis. So earlier in the presentation, we talked about some of those bursa, which are those fluid-filled sacs that offer lubrication, support, comfort. Uh, Essentially, when those get inflamed and irritated, you can get what's called the bursitis. So your knees, your elbows, usually caused by periods of prolonged pressure. So think of someone that always drives with their elbow sitting upright on the window, or somebody like a plumber or carpenter or whatever that's on their knees a lot, right? This is why you often encourage knee protection, elbow protection, just so you're not causing irritation to that bursa. Salter-Harris fractures. So these are your growth plate fractures. So these are in your children. So we have your normal growth plate, right? So that's where the bone is essentially extending and ultimately connecting to give you your size. So as you grow, your growth plate closes, but there's normal development. Uh, a Salter-Harris fracture is essentially the classification system we use to discuss that disrupted growth plate. So 1 through 5, you can use this fun little mnemonic here. So well, Salter, straight across, above, lower, through, and then a crush injury, right? R crush. So this tells you partially this. So this tells you where the break is in relation to that growth plate, as well as helps to guide your treatment, right? Some of these you can get away with more local treatment measures, a splint, a sling, and rest. As you get towards the end here, you might need to do more surgical interventions depending on the location and the severity of it, right? Because what you want to try and do is minimize the possibility for abnormal growth and development. So part of what you're doing when you consider surgery is creating a space to or creating an opportunity so that they have the best functional outcome. Obviously, you would consult your orthopedic colleagues for this. Rotator cuff exam. So we're not going to go through this in depth, but these are different maneuvers you can do to try and elicit and aggravate irritation at the rotator cuff. So as a reminder, the rotator cuff is in the shoulder, and this is the connection of those muscles and tendons to the different aspects of your bone. There's 4 components, so you're trying to elicit different irritation based off of where you think that irritation is coming from. So these are tests you can do to try and take you down a path of rotator cuff injury. Again, just a little bit more discussion on fractures. These are different types of fractures. So orthopedics is also a lot of terminology. So you've got your different mechanisms or your different descriptions of fractures, and then you can try and correlate these to potential mechanisms, right? So if you have a spiral fracture here, that comes from a twisting mechanism. So that's what this is showing you. So the big thing here is, yes, treatment and consideration, surgery versus splinting or so on and so forth. But your mechanism or the injury that you've been provided should match the actual fracture pattern. So if you have a fall, if you have a twisting injury, if someone's walking and gets caught in a pothole, or their leg gets caught in something and they twist, okay. This becomes more important with kids or even the elderly, right? So if you have a lot of fractures that are not explained based on their developmental age or based on their activity level, then we start thinking about things like abuse or anything in that spectrum. So as mandated reporters for children and the elderly, you have to be mindful of, the story you're getting has to match the objective data that you're also receiving. Now, what type of fracture is this? So I'll allow you to do this as independent study. Just look back and refer to your previous slide. These are the fractures here for your knowledge. It was a green strip fracture. Fracture is this. Comminuted fracture. Spiral fracture. So again, you see your breaks in multiple components, as if you were, take a pretzel stick and twist it, you're going to notice various degrees of fracturing throughout that stick. Same idea. Think of the bones like pretzel sticks, just a little bit stronger. More fracture-based information. So stress fracture, we didn't specifically talk about, but the idea is that you have a lot of wear and tear or stress to the bone, and as a result, a small part of that bone breaks. These are very common in the feet. So runners, endurance athletes, or anybody that is on their feet for prolonged periods is at a higher risk for stress fractures. This is again where education becomes important. So good recognition, good supportive footwear, getting off your feet periodically, so on and so forth. So sprains and strains, right? Tendons and ligaments, essentially getting overstretched and irritated. There's a variety of ways you can evaluate these. So determining whether or not to obtain an X-ray is a big part of what you're going to do if you go down this musculoskeletal route, right? So having a suspicion for fracture versus strain, and there's various tools out there. There's your Ottawa rules. These are the different levels of a sprain, which is essentially again that overstretching of the ligaments. And then just like anything else, the more severe it is, the more you're likely going to have to do for it. So if it's a low grade strain, bare weight, ambulate is tolerated. You can use your Rice mnemonic. As it gets higher, you can consider imaging. So this becomes interesting because you have your rules in here, and the X-ray is not going to show your ligaments, not going to show your tendons, but it's going to show the bone. So what'll happen is if you think about the ligament attaching from one end of one bone to another bone, if that gets stretched too much, they have the opportunity for a fracture in the sense that the ligament pulls away some of that bone, or it has such a hard grip on the bone that as the ligament stretches, it actually causes the bone to break. So again, that goes into your mechanism. Having an idea of how the injury occurred can be helpful in letting you know your suspicion for a bony fracture or injury. This is another version of a splint. There's a few of them in here. You'll also get a sheet of this at Immersion. These are finger splints. So they all have different applications. If you look down here, it can tell you when you want to use it, how you create it, and then how you apply it. Some different versions of splints. You have a lot of, so we just talked about those were like orthoglass-based splints or plaster-based where you're actually creating the splint. These are more pre-made, so they're already pre-molded or they're already, you can buy them at a local pharmacy, and you're using these as a removable splint. So it's the same idea, but it's much more user-friendly and it saves you a lot of time, and because you're not having to, with this, you're not only creating and molding the plaster component, but then you're covering with an ACE wrap and other structures, and it's got to dry, and it's just more in depth and time consuming compared to putting on a Velcro splint and going on your way. Compartment syndrome. I'd be remiss if we didn't talk about some of the more significant emergencies in regards to orthopedics. So compartment syndrome, if you think about your muscle compartments, I think so you have different compartments within your muscles, right? So it's multiple muscles put together that also have nerves and blood supply and so on and so forth between them. When you have injury or compromise to that area, natural reaction that your body does is swelling. So as that space decreases, some of those structures do not like it. As a result, you have some of these changes. So you can have pain, tingling, right? So if we think about, again, our anatomy, if you have those structures in there and now all of a sudden they're very restricted, you're going to eventually have some physical exam findings. The treatment of this is you relieve that pressure, usually through a fasciotomy, which is where you would go and actually cut open that compartment to alleviate some of that pressure as you wait for the body to naturally heal. So it's something to be very mindful of, especially in breaks or any kind of musculoskeletal injuries, because if this doesn't get evaluated, then the opportunity for just death of everything in this area becomes quite high. And then you look at things like amputation and certainly some other negative effects. Splinting and casting. So as you're applying splints, you have to be mindful of compartment syndrome, ischemia. So if you apply everything too tight, you have the opportunity to cause death to the cells in the area. Can't be too hot, pressure sores, infections, so on and so forth. So a big part of what you're going to do in the musculoskeletal spectrum is not only actually treating it, but providing education on things to look for and potential complications from any intervention that you do. And that's it. So again, just a general brief overview of some common disease processes within orthopedics that you're likely to see in primary care and clinical practice. Tip of the iceberg in terms of some other acute injuries in orthopedics. But this is a field, like I said, if you have the ability to do a standard exam from the beginning and kind of just apply that to different locations, then you're in a good spot in terms of orthopedics, right?